So good morning, everyone. It's a true honor to be able to join you today and to talk about my personal area of research, which is looking at high-risk or triple-negative breast cancer associated with African ancestry. So anytime we talk about healthcare disparities and health outcome disparities related to racial ethnic identity, the conversation invariably turns to a discussion of socioeconomic status. And this is certainly appropriate because, as you can see demonstrated on these bar graphs, our typical metrics of socioeconomic disadvantage, such as living below the poverty level or lacking healthcare insurance, both of these metrics are roughly 2 to 3 times more prevalent in our minority ethnic population subsets, such as the African Americans and the Hispanic Latino Americans. And it's easy to imagine how these types of socioeconomic disadvantages will translate into difficulties in accessing the healthcare system with poorer control of pretty much any medical problem, but certainly with likelihood of a worse outcome from a cancer diagnosis. And this is demonstrated by the bar graphs that I'm showing you on this slide, where we look at data generated by the Surveillance Epidemiology and End Results Program and analyzed by the epidemiologists from the American Cancer Society. And what Liz Ward and colleagues looked at were the 5-year survival rates after any type of cancer was diagnosed in American men and women, women shown at the top and men at the bottom set of bar graphs, and looking within racial ethnic subsets, these 5-year survival rates after stratifying for income level. And what you see demonstrated on these bar graphs is that poverty is indeed an adverse prognostic feature regardless of gender and regardless of racial ethnic identity. Within white Americans, within African Americans, within Asian, Pacific Islanders, within Hispanic, Latino Americans, if you're diagnosed with a breast cancer and you are poorer, you're going to have a worse outcome compared to the more affluent within your racial ethnic community. Now, when we look more specifically at the diagnosis of breast cancer, it is again very easy to imagine that if you have socioeconomic disadvantage, you are less likely to be screened appropriately for breast cancer and you are more likely to have an advanced stage of diagnosis. Ultimately, this will translate into a higher mortality rate. And over the next couple of slides, I'm just going to very briefly summarize how some of these socioeconomic disadvantages have a downstream effect on breast cancer outcomes when it comes to the African American and other minority population subsets. First, let's look at how these issues can translate into disparities in accessing advances in breast cancer surgery. Well, it's been demonstrated for several decades now that access to sentinel lymph node biopsy is poorer for the African American community. And in these data demonstrated by Chen and colleagues looking at information from the National Cancer Database, we see that among white Americans compared to African Americans diagnosed with early stage breast cancer, the African American breast cancer patients are significantly less likely to be able to avail themselves of the lymphatic mapping and sentinel lymph node biopsy procedure. And what's particularly disturbing about this table is that these types of disparities in accessing a wonderful advance in surgical management for breast cancer seem to actually be getting worse over time rather than better. And personally, I think that a lot of this type of disparity is related to the healthcare institutions where many of our minority breast cancer patients receive their care. A lot of our African American breast cancer patients are treated in the urban centers where there are some very large public hospital safety net institutions, and the safety net institutions are responsible for delivering cancer care as well as trauma critical care management of diseases. And so since they are situated in large urban areas, they tend to have very prominent surgical staff related to trauma and critical care, but oftentimes these general surgeons who specialize in trauma and critical care and trauma surgery will also be the general surgeons providing breast cancer surgery, and they will be less motivated to be trained and to develop expertise in some of the more refined or advanced patterns of breast cancer surgical management. So I think that that's one of the explanations for this type of disparity. Dawn Hirschman and colleagues have also looked at disparities in receiving appropriate systemic therapy, and in particular chemotherapy for breast cancer in the African American breast cancer population compared to white Americans. And what has been very fascinating in the work conducted by Dawn Hirschman and her group is that she demonstrated that a lot of the difficulties with African American breast cancer patients completing appropriate amounts of adjuvant chemotherapy is related actually to differences in white blood cell count and is related to ethnicity-associated baseline neutropenia. It's been recognized for many decades now that African Americans in general tend to have a lower average white blood cell count compared to white Americans, and this lower average white blood cell count actually doesn't translate into anything of clinical significance. But when we monitor these white blood cell counts for patients receiving chemotherapy, the downstream effect, of course, is that the African American women are going to more quickly have drops in their white blood cell count, such that their chemotherapy will either be discontinued or diminished in its amount. And this has been associated with the outcome disadvantages from the breast cancer disease. Another problem is going to be related to comorbidities that we see in the African American breast cancer population. And this problem is demonstrated very nicely by a study conducted in the Henry Ford Health System in Detroit, Michigan, where approximately a third of the breast cancer population is African American. And we see in these studies that a lot of the difference in survival from breast cancer between African Americans and white Americans was related to problems with other healthcare threats, especially diabetes and hypertension. And so the patients with these types of comorbidities were less likely to be treated successfully for their breast cancer diagnosis. However, it is also important to point out that these types of comorbidities did not entirely explain the survival differences that were seen between the African American and white American breast cancer patients in the Henry Ford Health System. So something else was still going on. We are now starting to look at disparities simply in the way that we deliver our messages about the way breast cancer treatment and other types of healthcare treatment should be administered to patients on the basis of the way we interact with our patients. And some of these interactions are related to biases that we might have subconsciously in terms of what we are perceiving as the racial ethnic identity for these patients. One landmark study that brought out these types of delivery of care disparities actually appeared in the literature related to cardiovascular practice of medicine. And this, I thought, was a fascinating study that was published in the New England Journal of Medicine more than 10 years ago, where the investigators did a very, very innovative model. What they did was to hire professional actors who are shown in the photographs over to the side of the slide, and all of these professional trained actors were specifically instructed to provide a videotaped recording of experiencing chest pain in an emergency room. And you can see that these professional actors are all wearing the same hospital garb, but they were specifically selected so that they differed by gender and so that they differed by racial ethnic identity. So these videotaped recordings of these professional actors were shown to more than 700 physicians attending different medical conferences. And after watching these videotaped recordings, the physicians were asked to simply respond in a survey about how they would manage these various patients, hypothetical patients. Well, when all of these survey data were compiled, what became apparent was that the African American women, the African American actors, were significantly less likely to be recommended to go on to have cardiac catheterization for further evaluation of their chest pain. And since these were all professional actors, they were specifically instructed to use the same text, to use the same mannerisms and facial expressions in describing the chest pain that they were experiencing. And so the authors, the investigators for this study, had to conclude that the physicians had some subconscious biases at play in terms of why they were recommending further workup based upon their perceptions of the patient's gender and racial ethnic identity. So the African American women were suffering from the dual biases related to their gender and their racial ethnic appearance. So I always want to emphasize when I describe this study that I do not believe that these physicians were being overtly discriminatory in their practice, But I think that what this study very powerfully pointed out is that we do all carry around subconscious biases, and in the practice of medicine, when we have to make snap decisions and be rapid and efficient with our healthcare treatment decisions, that sometimes these biases come out, and they can definitely have an adverse effect, unfortunately, on the outcomes of our patients. So the first step in eliminating these types of harmful subconscious biases, of course, is to just acknowledge the fact that they exist and then try to address them. So this type of work is now being replicated related to several other types of diagnoses, including breast cancer. And this was a really provocative study conducted by Jennifer Sang when she was a surgical oncology fellow at the MD Anderson Cancer Center. And what Jennifer did was to look at all of the patients in the MD Anderson database who required a mastectomy for their breast cancer diagnosis, and then they looked at how often women underwent breast reconstruction with the mastectomy based upon racial ethnic identity. So here I'm showing you just the outcomes for the African American women, but they looked at white Americans, African Americans, Latino Americans, women of all different racial ethnic backgrounds, and they looked very, very rigorously at what happened in the medical records of those patients. Were they referred to the plastic surgeon? If they were referred to the plastic surgeon, was reconstruction offered? If they were referred to the plastic surgeon and reconstruction was offered, was it ultimately performed? And for the African American women compared to the white American breast cancer patients requiring a mastectomy for their cancer management, in every step of this process, there were statistically significant decreases in the African American women being referred on to breast reconstruction. So I worked at MD Anderson for several years. I love that institution. It's marvelous, and many dear friends who continue to work there, and I certainly know firsthand that the surgeons there are not being overtly discriminatory in their treatment recommendations. But again, things can happen that we're not even aware of when we are interacting with patients, where biases get interjected into the conversation related to what we think the patient might be interested in and what we think the patient might be ready to pursue. And these are more related to our own personal internal biases rather than what the patient truly needs for their management. There are also huge disparities in the profile in terms of racial ethnic identity of our healthcare workforce. And this is certainly not a problem that's going to be addressed overnight. It's going to require many years, many decades worth of mentorship and overhaul of our educational system and of professional opportunities that are offered to the diverse populations of this country. But what I'm demonstrating here is that African Americans and Hispanic Latino Americans are woefully underrepresented in the healthcare field, whether you're talking about membership in the American Medical Association, membership in the American College of Surgeons, or membership in cancer clinical trial cooperative groups, such as the American College of Surgeons Oncology Group. While these population subsets account for about 12–13% of the general population, we only account for about 2% of the healthcare workforce. And I am not somebody who goes around advocating in favor of patients being matched by gender or racial ethnic identity to their physician, but I do very strongly believe that patients in general will have greater trust in the healthcare workforce if they see a workforce that better reflects their own community. So it's reasonable to ask the question of why, if we have so many different factors that can explain disparities in breast cancer outcome related to socioeconomic access, why in this era of very, very limited healthcare research dollars would we continue to try to study the possibility of there being in existence primary differences in tumor biology related to breast cancer and racial ethnic identity? Well, one reason is apparent if we look at this meta-analysis that I had the pleasure of conducting several years ago, where we pulled together the data from all of the studies appearing in the published literature, looking at survival from breast cancer, stratified by racial ethnic identity, and after accounting for some measure of socioeconomic status. So this pooled analysis gave us a very robust population to evaluate, more than 13,000 African American breast cancer patients whose survival was compared to more than 75,000 white American breast cancer patients. And when all of these data were pulled together in the meta-analysis, what we saw was that there continued to be a nearly 30% higher mortality risk for the African American breast cancer patients compared to the white American breast cancer patients, again, after accounting for socioeconomic status. And if you look simply at the other features that describe the breast cancer burden of African Americans, the lower lifetime incidence of the disease, yet a poorly understood younger age distribution for breast cancer in African Americans, and for women younger than the age of 45, breast cancer incidence is actually higher for African Americans on a population basis compared to white Americans. And African American women with breast cancer are more likely to have adverse tumor features such as high-grade lesions, estrogen receptor negativity, and triple marker negativity. And there's also a higher incidence of male breast cancer in the African American community. None of these latter features can be easily ascribed to socioeconomic access and socioeconomic status. So it does then become incumbent upon us to look at whether or not there are some primary race-ethnicity associated variations in tumor biology and the genetics of the disease. You might surmise that looking at clinical trials data would be one powerful strategy for disentangling racial ethnic identity and socioeconomic status from cancer outcome. And this is where Kathy Albane and colleagues from the Southwest Oncology Group conducted a really provocative and powerful combined analysis of the SWOG adjuvant therapy trials. So what they did in this analysis that was published in the Journal of the National Cancer Institute just a few years ago was to look at all of the different adjuvant therapy trials conducted by SWOG for a variety of different cancers, and looked at outcomes related to racial ethnic identity in an attempt to answer the question of whether equal treatments delivered in the context of a clinical trial would translate into equal outcomes regardless of racial ethnic identity. And indeed, it was very reassuring for us to see that for almost all of the cancers that they looked at, outcomes were the same in the context of participating in a clinical trial for patients of different racial ethnic identities, except when it came to the cancers that were hormonally driven, breast cancer and prostate cancer. You still saw, even within the context of a clinical trial, outcome disadvantages for the African American clinical trial participants. And the table at the bottom of this slide is simply summarizing the data from the breast cancer trials that were discussed in this particular study, with African American women, both premenopausal and postmenopausal, having a worse recurrence and a worse mortality rate from breast cancer, even though they were participating in these very well-designed and regimented clinical trials. I was very concerned by the review that Time.com published about Kathy Albane's trial, because they entitled this review of her study, "Why Racial Profiling Persists in Medical Research." And of course, racial profiling has a lot of very negative connotations, and rightfully so, but I thought it was inappropriate for them to talk about the Albane study in the context of racial profiling. Nonetheless, the author did make a very important comment at the end of her evaluation, where she said that to close the gap in health outcomes, the key perhaps is not to control for socioeconomic disparities, but to try to eliminate them altogether. And that certainly is appropriate. But when it comes to cancer studies, racial profiling is really just epidemiology, and we absolutely have an obligation to look at all of the features, all of the characteristics that describe our cancer patients, and then correlate these characteristics with response to treatment and outcome from treatment. And if you look at just these very basic population-based survival and incidence curves from breast cancer for the African American and white American populations, you'll see what I mean. It's been known for several decades now that incidence rates over the lifetime of breast cancer are lower for African American women compared to white American women. And when incidence rates of breast cancer rise over time, you see a parallel increase in these incidence rates for African Americans, but there's this persistent difference in these incidence rates. The curves are different, however, for population-based breast cancer mortality rates, as shown by the curves at the bottom half of this slide. And mortality rates from breast cancer were actually the same on a population basis for African Americans and white Americans until you got to the early 1980s. And at that point, you see a separation of these curves, primarily explained by a decrease in mortality rates for the white American population, whereas the mortality rates for African Americans, for the most part, stays the same. And this is, of course, because of the fact that tamoxifen was introduced in our armamentarium of systemic therapies for breast cancer in the late 1970s. So by the early 1980s, we start seeing a reflection of the fact that African Americans are more likely to be diagnosed with the estrogen receptor negative breast cancers, which of course are not going to be impacted significantly by use of adjuvant endocrine therapy such as tamoxifen. So this approximately twofold higher frequency in ER-negative breast cancer is apparent in African Americans compared to white Americans. And this difference in ER negativity is seen regardless of age at diagnosis, regardless of stage at diagnosis, and regardless of income level. Lisa Carey and colleagues have gone one step further to demonstrate the higher frequency of triple-negative breast cancers in African Americans, especially in young premenopausal African Americans. And that these types of findings have been replicated now in several different institution-based studies and population-based analyses. Similar to what we see with estrogen receptor negative disease, the higher frequency of triple negative tumors is more common in African American women compared to white American women, regardless of the age at which they're diagnosed and regardless of the stage at diagnosis. And these differences spill over into the discussion of when we should be screening women in the United States for breast cancer using mammography. As everybody in this audience is aware, in November of 2009, the United States Preventive Service Task Force issued an updated publication related to their analyses of the historic mammographic screening studies, and they ultimately came to the conclusion that American women should defer initiating screening mammography until they reached age 50. I and many of my colleagues were very disappointed in this recommendation because they failed to comment at all on the potential impact that such a recommendation might have on breast cancer disparities. Since African American women, as demonstrated in this study from the California Cancer Registry, African American women have higher population-based incidence rates of triple-negative breast cancer, and this is seen at every decile of life. If you delay screening mammography in African American women, you run the risk of worsening these survival disparities. Now, the features that we describe as explaining the breast cancer burden of African American women: younger age at diagnosis, higher frequency of adverse tumor features, and higher risk of male breast cancer. These are all the same features that, of course, describe the breast cancer burden of women with known hereditary susceptibility, such as BRCA1 mutation carrier status. And so this then begs the question of whether or not African ancestry in and of itself might be associated with some heritable marker predicting for risk of these patterns of disease. And studying breast cancer in women from Africa who have shared ancestry with African Americans then is a very unique opportunity for us to learn about the etiology and pathogenesis of triple-negative breast cancer. And so this is why I and my colleagues at the University of Michigan have embarked upon an international partnership where we are studying the breast cancer burden of African Americans, white Americans, and women from Africa, specifically Western Sub-Saharan Africa, as represented by the Ghanaian population, to learn more about these triple-negative cancers. The hospital that we've partnered with in Ghana is the Komfo-Anokye Teaching Hospital in Kumasi, Ghana. And in one of our earliest comparisons, we saw exactly what we expected to find. The Ghanaian women were the very youngest at average age at breast cancer diagnosis. The eldest average age at diagnosis was seen in white American women. Highest frequency at more than 3/4 of the women in Ghana having triple-negative disease, lowest frequency of triple negatives being seen in white American women, and African Americans always being intermediate between the Ghanaians and the white Americans in a whole host of these tumor features. The experiences of the Comfort Teaching Hospital are replicated in the Korle-Bu Teaching Hospital located in Accra, Ghana, where again we see that more than half of the women in this hospital are diagnosed with triple-negative disease. Far greater percentage than what you see in white American women and European women, where only 15% of breast cancers are triple-negative. So we then surmise that there is indeed something related to extent of African ancestry that drives the risk for having this pattern of disease. Whether you're looking at average age at diagnosis, frequency of male breast cancer, frequency of these various tumor markers, there always seems to be the extremes between Ghanaians and African and white Americans, with African Americans expressing those patterns to an intermediate degree. And so we think that this is related to the degree of genetic admixture that's occurred in the United States over the past 4 centuries. Since, however, Africa is still the founder population for all of humankind, if there is some heritable marker for this pattern of disease, you will absolutely see it expressed in women worldwide. Now, it's been demonstrated by several epidemiologists that the classic risk factors in terms of reproductive history seem to be different for triple-negative breast cancer compared to non-triple-negative breast cancer. And here's one example. Multiple pregnancies historically predicts for a lower likelihood of being diagnosed with breast cancer, but this is largely because it protects against non-triple-negative breast cancers. Multiple pregnancies in several studies actually increases the risk for having a triple-negative tumor. And so some investigators have then hypothesized that maybe it's these childbearing patterns that increases the frequency of triple-negative breast cancers in women in developing countries, because these women are more likely to start childbearing at younger ages and more likely to have multiple pregnancies. But if you look at the frequencies of triple-negative breast cancers that are identified in women from Africa, they are still much higher compared to the triple-negative breast cancers frequencies that you see in women of other developing countries, where you would expect there to be similar or comparable childbearing patterns, with several studies demonstrating more than a third of women in Africa having triple-negative tumors, but fewer than 20% in women of other developing countries having triple-negative tumors. So we've gone on to study other types of markers of triple-negative disease, notably the stem cell marker ALDH1, and in the interest of time, I'm going to run through the following slides very, very quickly. But in general, what we've seen is that ALDH1, as a marker of the mammary stem cell, seems to be expressed in a significantly higher degree in Ghanaian and African women, both for the cancerous tissue and for the benign tissues. Another marker that seems to be associated with stem cell progression and triple-negative breast cancer progression, EZH2, has some unique features in the Ghanaian population, as demonstrated by my colleague in pathology, Dr. Selena Clear, at the University of Michigan. So we are now learning more about heterogeneity in triple-negative tumors and triple-negative breast cancer subtypes, so it becomes very important for us to figure out the biology of the triple-negative breast cancers that we are seeing so abundantly in women with African ancestry compared to the triple-negative breast cancers that account for just a minority of white American women. And this is why we've gone on to create a library of xenografts from triple-negative tumors in women from Ghana. And this has been a very challenging feat, but we have actually been successful now in creating xenografts from these tumors. So I believe these international partnerships are extremely exciting from a research perspective, but they are also very exciting just from the perspective of being able to invest in the healthcare standards of countries that are so very, very badly in need. The last remaining slides are just some photos of the hospital where we work, and you can see in the surgical suite, most of the stretchers don't even have sheets on them. The photograph at the bottom is what is supposed to be the sterile scrub sink area. You know, the resources there are just extremely, extremely limited. But the community there is very welcoming of our partnership, and we have been very gratified by being able to invest in the multidisciplinary tumor board conferences of the hospital where we work. We've developed a core needle biopsy training program there, and we've also established an immunohistochemistry program at this hospital, whereas before this partnership, they were not even able to obtain ER, PR, and HER2 new markers on their patients. This again shows how this partnership has been going on since 2006, but we have several generations worth of folks who are now involved with it. Over here, I love this slide because this was at my son's 11th birthday, precocious kid showing the peace sign there, and several of our colleagues from Ghana were visiting at the time, and I use this slide as an example of how they got to see about how a bunch of very, very spoiled American kids live. But here, most recently, my son is now 16, and he traveled with me to Ghana, and he's become very, very invested in being involved with this research process itself. This young lady is Dr. Evelyn Jagay, a surgeon from the Comfort Teaching Hospital, and she is going to take over this program in Comfort after, I'm proud to say, after she completes her PhD work with my colleagues at University of Michigan, Dr. Sophia Mariver and Dr. Max Wisha. And whenever I talk about breast cancer disparities, I always close by showing these three survival rates of 60%, 43%, and 20%, which don't actually have anything to do with breast cancer, but these are the survival rates of the first class, the second class, and the third class passengers of the Titanic. And I always close with these statistics because it's just an important reminder that even though for the specific issue of breast cancer, there do seem to be features related to African ancestry that drive risk for certain patterns of disease, when it comes to any healthcare threat, whether it's a cancer diagnosis or surviving a sinking ship, survival, unfortunately, is totally dependent on access. And just as many of our minority, racial, ethnic subsets do not have access to the best health care, so also the third-class passengers of the Titanic did not have access to the lifeboats. And to close with a quote by the Reverend Dr. Martin Luther King, Jr., of all the forms of injustice, inequality in health care is the most shocking and inhumane. And so I thank you all for your attention.